Good afternoon, everybody. Welcome to Grand Rounds today. Today I have the pleasure of actually introducing two speakers. Dr. Shane Hopkins, who is a radiation oncologist and a member of the MGMC medical staff for approximately the last 11 years, has kindly accepted our invitation today to provide us with an overview and review of the diet and anti-diet culture. And then Rachelle McCabe, who has had an extensive amount of experience in managing patients who have bariatric issues, is going to be giving us a review of one of, I think, the most popular classes of medications in the United States right now, and that being the GLP-1 agonists. And so without further ado, please join me in welcoming Shane Hopkins and Rachelle McCabe.
So I'm really excited to be here. This is a talk that obviously is not part of my normal scope of practice. It's not something that I'm board trained in or something that I've got formal education on. But it is a topic I've been interested in both personally because it's relevant to my patients and my family members. And it's an area where I've seen that there's a lot of opportunity for improvement in the practice of medicine. At our institution, as a preparation for this, I actually polled Ames people, that wonderful place where you can find out the pulse of the community here, asked people what their experience had been, and there were some people who said they had had a negative experience with some of the clinicians in our community. Not any individual single clinic, not any individual single specialty, but people who they felt they were mistreated because of their body size or because of some concerns that they had associated with that. And I just wanted to sort of draw attention to this and point a spotlight at it and talk to you, not because I have all the answers, but because it's an interesting topic and hopefully engender some conversation. So the take-home points today: first, recognize and mitigate anti-physician sentiment when clinically addressing obesity and body composition. You may not know it, but you've probably had patients, if you've told patients to be weighed and then you told them that they need to lose weight because of a health issue that they have, you may have made them really angry at you without them actually saying so. And so I think you need to understand why some people feel that way and why there's a little bit of an anti-diet culture movement to push back against the way that we manage weight. Empathize with patients who struggle to establish recommended lifestyle changes. I think that there is a certain sort of social attitude towards body composition, that it's a matter of willpower, it's a matter of determination, it's a matter of personal discipline and control. And that is understandable because to a large extent it is, but to a large extent it isn't. And that's important to understand. And it's important to empathize that we don't have all the answers and that what applies to you as a type A clinician, personality who's very achievement-oriented and very able to achieve and do things that are remarkable may not be easy for other people, may not be possible at all for other people. So empathy is important. Discern between more effective and less effective interventions for modifying diet and activity. So some diets are better than others. Some people say any diet is better than none, just watch what you eat. Sometimes that's not true. There's actually some movement towards intuitive eating, and that has been successful and has some advantages. There's also things that we could talk about activity, and that hasn't been a focus for my presentation, but certainly there's lots of different recommendations for activity, and some of them we give to patients may actually be counterproductive. And so you need to recognize some things are more effective, some things are less effective. You need to tailor it to the individual patient. And it's hard to do that unless you actually ask them about their status, what they've tried, what has worked or hasn't worked in the past, if they've had a history of an eating disorder that has involved exercise and activity, and find out those individual clinical circumstances that maybe you just gloss over, and maybe you're tempted to just be like, that's not part of my specialty, so I'm not going to get into it. But you will have an impact on them, so you need to make sure that you're aware of this and you include it. So disclosure, I do hold Eli Lilly stock. Mounjaro will likely soon be FDA approved to treat obesity, and I'm a big fan of Mounjaro and the other GLP-1 drugs. How did this happen? So actually I'm a cancer doctor, as previously mentioned, not an obesity medicine specialist. And I actually have patients who all the time ask me, why am I here? What happened? How did I get into this situation? And it's an opportunity for me to be culturally competent and recognize there are multiple correct answers. I could tell them it's because of a virus you got from a sexually transmitted disease many years ago. I actually had a patient who asked me about her HPV-caused head and neck cancer with all of her family with her, this 80-year-old little old lady. And I was, not eager to talk about the sexually transmitted virus that caused this for her. So, you have to be culturally competent. You have to make sure some people do believe that their cancer is, a challenge that's come to them from God. But I do think that when I discuss causes, I like to focus on what can be done about it. And we talk about what can be done about it. We want to make sure we tailor it to the individual. We want to make sure that we talk about both the risks of interventions and the benefits, both. That's true for obesity medicine as well. When you're talking to someone and ask them to try to lose weight, there's risks associated with attempting to lose weight. You may actually have rebound or yo-yo dieting or metabolic disorders that result from that, genetic changes that actually make it more difficult in the future to maintain a normal weight. And you need to cover both sides of that equation, not just say, lose weight, that's going to solve your problems. I'll see you next time. That's not a responsible way to interact with patients. So I do have a few cases, and if you'd like, you can bust out your phone and participate in this part. Hopefully you saw on there's a Menti code. It'll be on the next slide. If you want to go to menti.com, you can put in this code. A patient presents for a sore throat. When getting vitals, the nurse attempts to weigh the patient. He declines and wants to know what his weight has to do with a sore throat. These cases are actually real. These things have happened, and people have confided to me or told me that they had these experiences and they were bothered by it or they had a particular response to that. So how do you respond? Get out your menti.com and put in 78941238 and pick whichever of these you think reflects most closely the answer you like. This is not there's a correct answer based on your board exam or something like that. This is just me brainstorming what people might say. Tell him his obesity has compromised immune system and rendered him sickly, so tracking weight is a part of treating the sore throat. Advise him it's just a vital sign like blood pressure, so don't worry about it, but we just really need to get it. It's part of our process. Number 3, don't get the weight, just move on, unless he reports a recent weight change and you need it for antibiotic prescriptions or something like that. Or ask him why having his weight measured bothers him, why he brought this up, and probe for potential disordered eating. So if you have a moment, go ahead to menti.com, put that in there, and we'll just see how we do on this. If I can figure out how to exit this. Hold up. All right, so people are favoring the third response. Don't get the weight and move on unless he reports a recent weight change and you need it for antibiotic prescription. I think that's probably the best answer because the fact is we have our processes and sometimes we feel put out when a patient does something that causes us to, do things differently than we're used to. But we need to remember that we're a partner for this patient's healthcare and it's actually a matter of, advocating for them and helping them to solve the problem, not being about checking all the boxes. There's actually an interesting thing I wanted to bring up during this talk is as McFarland physicians, we're an accountable care organization. We share responsibility with Mary Greeley to take into account the cost of healthcare and make sure that we're delivering high value at low cost as much as possible. As a part of that, we want to address the complexity of the healthcare that we deliver. And so we want to make sure we put all the HCC codes on a visit that are applicable. If you treat this diagnosis and that, if you treat 10 diagnoses, then it's actually calculated in the ACO differently than if you just put one HCC code on that visit. And so we're encouraged as part of our, delivering high quality care and making sure we're reimbursed appropriately to put all the codes on that are applicable. So if you address obesity and you tell the patient they need to lose weight, that gets you an extra HCC code. And then the patient gets a discharge summary that says that you said they were obese and need to lose weight. And sometimes they can get really angry about that because it's not relevant to their sore throat. And they want to know why you did that. And you just did it because you're trying to do right by McFarland Clinic and the ACO and make sure you're capturing, all of the things that you address there. That's something that we don't necessarily think about, but can actually turn off patients. They don't want their weight addressed. It actually causes them psychological distress to always be told they're not what they should be in terms of their size, and they've struggled with that with their therapist, and they're told to don't get a weight, just turn away from the wall if your clinician, insists that you need to have your weight measured so that you're not seeing it. Tell them you don't want it printed on your discharge result. And sometimes clinicians are not very accommodating of that, and they're just too much work to go and take it off of the discharge summary. And so it just gets put on there anyway, but it actually affects them and their psychological, their therapy or whatever the case may be. So it's actually something you may not think about, but that's one of the issues there. So it's also very reasonable to ask him why having his weight is measured and make sure that there's not some potential disordered eating for which you would need to refer him to someone else. And I think it's probably also true that it is a vital sign that it's good to get that tracked over time so that that can be addressed in other clinics. And so just like in my clinic, it's important to do depression screening and the blood pressure and all these other things that are may not relevant to what we're doing that day, but it helps us refer people back to other, to their primary care doctor to have those things addressed. So you could say the weight is just part of this. And I appreciate that no one chose 0 because that's a little bit of a BS answer. But so just getting back to this case number 2, let me just go back here. A patient has shortness of breath for which she is given the advice to lose weight. She has returned to the clinic several times with a similar complaint. She gives a very unfavorable score when surveyed about the visit afterward. So this is a case that's from real life. This is a person that I know, and she has weight as a risk factor for some cardiac issues. But all she was told that she could do about it is just, you need to lose weight, period. See ya, out the door, bye. She's not happy with that answer. And so, the advice wasn't wrong, but then the question is that really helping the patient to just say lose weight, or is there more that we can do? So these are the examples. Ignore it. This can't be avoided because patients get angry when doctors don't solve all their problems despite having not done anything wrong. Number 2, refer the patient to a dietitian for discussion of weight loss options she may not have considered. Number 3, discuss medical management using diabetes medications like the GLP-1s we'll be talking about later, off-label to bring weight down. Number 4, plan for a more thorough conversation about what she has previously tried in terms of weight loss, and then choose a new approach together. If she's already tried and she's not been successful with it, just telling her to lose weight isn't necessarily a productive thing to do. So if you want to go ahead and put your answer in on what you think the best manage is for that one, we'll go to that next one. Oh, yeah, we got a pretty solid consensus on this one. That's good. I don't think it would be wrong to do that third one, discuss medical management using diabetes medications. You can do that. You can also have a more thorough conversation before you jump to medications. That's probably a better answer. Or referring the patient to an obesity medicine specialist or someone who can help put this into perspective and from an evidence-based approach, make sure that they're doing it in a way that's culturally competent and successful and not just giving people tired tropes that we actually know from the literature don't necessarily work. So there's actually several of these that probably could be done. But yeah, we got a consensus. That one's pretty uniform. All 24 people said on that, so we'll take it. All right, so just moving on. Is being fat bad? And I think that this is fundamental to the reason why I even gave this talk, because I do think that we live in a diet culture world in which Instagram models, or I was talking about, this is how you can make yourself look better. This is how you can be more fit. This is how you can be, your clothes will look better. And it's something that the vast majority of our population aspires to. And we value being attractive, and we associate being skinny with being attractive. And that's a cultural phenomenon. So, is it wrong aesthetically to be fat? Subjectively, I think our society believes that it is, and that being skinny is more beautiful. And so that's the world that we live in, and that's what you're dealing with. And what that means is that people who don't fit that sort of arbitrary definition of beauty are told that they're not as good, that they're not everything that they should be. And they're not only told that if they're morbidly obese and taking up 2 airplane seats, which is a whole separate issue, they're told that if their BMI is 27 and they're not, supermodel perfect. They're told that, you need to lose some weight. You could really, rock those clothes if you just got them to fit a little bit looser or something like that. So aesthetically, yes, being fat is bad, but that's not actually based on objective information. That's based on societal, cultural, arbitrary stuff. And frankly, it's harmful. And so I think people know that, but it's also something that's so ingrained in our culture that literally less than an hour ago, I was talking with a patient who feels like he needs to lose belly fat, even though he was not overweight at all. And he was seeing me for a completely different reason. It's just ingrained in our society. This was like an 80-year-old guy who, just wants to have a six-pack still. He's 80 years old. I don't know that that's a reasonable, achievable goal for him. So we had to have a conversation about that. What about morally? Well, this is another area where people associate being overweight with being lazy and gluttonous and slovenly and lacking in self-discipline. And there may be some component to that sometimes, but judging that categorically is absolutely inappropriate. It's hurtful and it's bullying. And you can see that when you go online and you read some of these conversations like Lizzo and, some of these people who, they just get hammered and they just get harassed and they get told, hey, I'm not trying to just, blast you personally. I'm just worried about your health. So that's kind of what I wanted to talk about. Is obesity really a disease or is it more of an adaptive thing? So actually was on the Council on Science and Public Health of the American Medical Association in 2005 when we first had a resolution that was asking whether obesity is a disease and whether the AMA should come out and say that obesity is a disease. And so as a medical student, I had the opportunity to be involved in that discussion. We produced a report. The result of that report was we said, we don't think it's a disease. We don't think it satisfies the criteria of a disease. And sure enough, almost 10 years later, I had just barely finished a term on the CSAF on the same council as a resident, and they brought up the exact same issue again. So the report that was generated by the AMA's Council on Science and Public Health in 2013 pointed out there's some serious problems with considering obesity a disease. One is the obesity paradox in the middle health. While comorbidities generally increase as BMI increases, a number of research studies report no effect or even slightly protective effects of overweight and obesity on mortality risk. I can tell you when I have someone come in with head and neck cancer and they're about to get chemotherapy and radiation for 7 weeks, if they've got a few extra pounds on, I'm celebrating that because they are going to be more comfortable. They're more likely to get through the treatment without needing to take a break. Their cancer is more likely to be cured because of that. They're less likely to end up in the hospital with side effects and toxicity. They are being protected by that extra weight. And that is demonstrated in the literature, it's demonstrated in the data, and it's a scale. But yes, relatively, people who are overweight and obese in certain circumstances, it is more healthy. So how is it a disease if it's actually more healthy in certain circumstances? And then the other argument is just how are you going to talk about the definition of a disease when we actually don't have a widely agreed upon definition of disease in the medical literature? And that's part of what the report talked about. So the medical community's definitions change. They're heavily influenced by context of time, place, and culture. And it's imperative to consider the potential advantages, disadvantages, incentives, and obligations of the disease label. Well, if we want to have it paid for, so someone comes in and they're overweight, and you say, well, that's just an adaptive situation. It's just from excess calories, and the body is functioning exactly as it should to store those extra calories as fat tissue. That's not a disease. Well, it still may cause serious other health problems or be a serious enough risk factor that it can really hamper their quality of life, and insurance is not going to pay for it if you don't call it a disease. So that's kind of the give and the take. If we say it's not a disease, then we can't treat it. And even if it's not a disease, there's still some major value in having the flexibility as a clinician to be able to address it if that's appropriate with the patient's goals. But, if it's called a disease, it's much more likely to be paid for. So that's kind of where we're going with this. So the CSAF report recommends focusing on root causes of obesity rather than labeling it as a disease. So we said again in 2013, it's not a disease. Or you could call it a disease, but that's a bit of a stretch because it's really more of an adaptive thing. But there's lots of different definitions. So if you want to call it a disease, okay, maybe. Guess what? Resulting AMA policy, it's a disease. They're just going to call it a disease. Policy at the AMA is by vote. So the doctors debate back and forth what they think the best way forward is, what's going to help patients, what makes the most sense. And it's consensus building. We try to come up with what satisfies the most people. This is controversial. You talk to different doctors, they may not all agree on that. I know Rachelle is going to touch on this to some extent here as well. So I'll let her take more time on that. But public perceptions may shift as a consequence of more extensive recognition of obesity as a disease, but not in a manner that improves health outcomes. So the council was concerned that if people are told it's a disease, we're like, well, I have no control over it. I don't need to exercise. I don't need to change my diet and that sort of thing. So it's interesting that the anti-diet position is it's not a disease. Obesity is not a disease, but for that very same reason, you don't have to, and trying to change your behaviors, whether that's exercise or diet, may be counterproductive and can't influence your weight. And so I don't know that the CSAF report tried to anticipate these problems that might come from classifying it as a disease or not. and it's just blown up. There's all sorts of confusion and, people who have different opinions all the way through this. And so, but right now, the AMA considers it a disease. There are codes that consider it a disease. It's reimbursed as a disease, and that helps in some extent with getting healthcare for it. And that's where we're getting to where certain GLP-1 medications are coded for, treatment of obesity as well. So again, back to sort of what the impetus was for me giving this talk at all. I read this book. It's called Anti-Diet, and she focuses on diet culture. She defines diet culture as a belief system that worships thinness and equates it to health and moral virtue, promotes weight loss and maintaining a low weight as a way to elevate social status, and demonizing certain foods and eating styles while elevating others. Her position is that that's all garbage. It actually leads to poor health, takes away your time, takes away your money. It's trying to fill shoes that you don't need to fill. There's nothing wrong with your body the way that it is. Appreciate your body. If it's a larger body, great. If it's a smaller body, great. Eat when you're hungry. Don't try and deny yourself. That leads to eating disorders. So that's basically what this book is, and that's where the term diet culture comes from, at least for me.
I don't care whose plan you adopt. It can be Bernie Sanders' plan. It can be Elizabeth.
This is Bill Maher. We're going to listen for a
It can
minute.
be the man in the moons. It's not going to work because the people are not participating in their own health, and they are never asked to. And then, did all the facts about obesity but he's right. Unless we get a handle on this, unless we look in the mirror on this, unless we're realistic with ourselves, because we're through the looking glass on this, where we don't, the fat shaming, how dare you? Actually, we fit shame. We say to people, eat something, who are not overweight. You have blood on your hands because you are not helping people by normalizing something that is, factually the number one killer in America. It was before COVID. It was killing people slowly. And with COVID, of course, it killed them quickly. We know these are facts. 78% of the people who were hospitalized or died from COVID were obese. I mean, I don't know why this is such a controversial subject. Obviously, I understand people don't want to be confronted with their failures. I don't. I have many failures. I said in that piece that James Gordon was attacking that there was a time in my life when I drank too much, and I understood that. And people said to me sometimes, maybe you should go a little less heavy on the drinking. And I would say to them, yeah, you know what? You're right. I should. And then, of course, I wouldn't. But I didn't say, how dare you drunk shame me?
Right.
There's a big difference between coming back at somebody and saying, how dare you even mention this? And saying, okay, I got it. You know what? You don't have to push in my face. It's easy to be, this mean man, Bill, this mean guy is saying mean things, and here I am coming to your aid. And I've heard people say this many times when this comes up. People struggle with this. I've had that come back at me a number of times, to which I say, of course they struggle. Everything is struggle. Life is a struggle. But look at people 50 years ago. We look like a completely...
Just for time, I'm going to skip the rest of that. But I feel like he lays out the diet culture talking points that are, emphasizing, that fat shaming is for your own good. Fat shaming should not be a bad thing. We shouldn't be skinny shaming people, that it's pushback against the anti-diet culture where people are like, stop fat shaming people. And they're like, well, you're skinny shaming people. So it's like, you can just see where this just gets to be controversy and wrapped up in celebrity spats. Him and James Corden went back and forth arguing with each other. And so anyway, here are some of the things that I took from that clip. People are not participating in their own health and they are not asked to. Let me just tell you right now, you do not need to tell a fat person that they are fat. And you do not need to tell them that they would, potentially get a lot less flack from society if they were thinner. They know that. You're not going to help them by, trying to fat shame them or tell them you're just unhealthy and you need to shape up. That is not constructive. That's just ridiculous. It's bullying. So people are not participating in their health and they are not asked to. They are asked to, and they've been bullied their whole life if they've been overweight their whole life. So that's not really the issue, that they're just not aware that being obese is an unfavored status in our society. And they're also probably not aware or not unaware that it has health implications. They're aware of that, but they probably would take issue with what some of those are, and it gets into an argument on there. So, this kind of sensationalized language of blood on your hands. And, there's other clips I've seen on TikTok where influencers are like, what I'm not going to do is normalize obesity and act like it's just totally acceptable. Well, maybe you should just take a step back from trying to, preach and judge other people. And as doctors, this is the same thing. Have the humility to recognize that things change over time. We get a more nuanced understanding of things, and this issue is complicated. And we need to step back and look empirically at what's going to be the most productive for the person that we're talking to or the person in this situation. So people don't want to be confronted by their failures. Or people want to not be judged by you when you have no idea if this actually is a failure or if it's a decision or if there's some background of an eating disorders. It's like such loaded language. And, as I listened to this clip, I was like, I've been there. Like, I could have said exactly the things that he's saying before I kind of started looking into this, because I'm like, it's just a fact. Being obese has health consequences. I'm not trying to be mean by saying that. It's just a fact. It's more nuanced than that. And so I'm going to go through some of these diet culture talking points as well as the anti-diet culture talking points. So in that book, Anti-Diet, she points out diets don't work. She's not just making that up. We've studied this. This has been studied with meta-analyses and, all sorts of places, and diets have not been successful across, a general population, no matter what the diet is, no matter, what the follow-up is. Sure, people will lose weight initially, but they gain it all back, or at least the majority of them gain it all back. And there's data. They're working from scientific data and pointing that out. So when you're telling someone, just diet, just diet, just diet, if it were that easy, people would be doing it more often and more successfully. So attempts to diet result in worse rather than better health. Medical interventions for weight loss have been historically morbid and ineffective, like bariatric surgery. It's got its drawbacks. Obesity is not a disease. So that's one of their talking points. They disagree with the AMA's determination. They agree with the Council on Science and Public Health's determination that it's not really satisfying the criteria of a disease. Again, you can make that decision and disagree on it. Societal views on ideal size change over time are not health-based. That's back to whether we're talking about from a aesthetic, societal point of view or from a health point of view. Poor health associated with obesity is categorically a result of social stigma. This is one I disagree. I think it's not true. And maybe I've overstated how she says it. But she thinks that all the things that you see, they're, negative health outcomes associated with obesity, it's not from the obesity. It's from the horrible, the hormonal changes and the social isolation that happens because we just badger and harass people who are overweight. That's why they have poor health outcomes. That's her position. There's some truth to that. I don't know that I'd be as categorical to say that it's all the problems that are associated with obesity, but it's real. It's been studied. Healthcare training has perpetuated biases and misinformation about obesity. I think that's true. I think that we've oversimplified things, and I think doctors are way overconfident that they've got it all figured out. As recently as yesterday, I was arguing out a physician Facebook group with some doctors who, some of whom were way outside the area that they had any idea what they were talking about, but had perfect confidence that they were right. Calories in, calories out. It's simple physics. It's just a matter of just, making sure that you have a calorie deficit and then you live happily ever after. It's not that. I'm sorry. You just need to go review the data. You have no idea what you're talking about if you think it's just that simple. Yes, it's true on a physiological basis, but we don't practice, we don't live in an isolated, single chemical experience over 24 hours. We live in a context of decades. So the question is, how does that play out over years? How does that play out over time? All right, dealing with doctors. In the book Anti-Diet, she says, if you have a doctor who just won't listen and just clings to this misinformation, fire him. And I don't disagree with that, to be honest. So let's not be those healthcare providers who are impervious to new information and to being sensitive to people who come in who are outside of what we, think that we already know. Let's go ahead and listen instead of talk if it's not something we're an obesity medicine specialist. I'm going to skip this slide because I'm running out of time, but basically healthcare providers are given their marching orders in this book. I think she goes a little far on this. This is a little bit more reasonable distillation of what healthcare providers can do. Try to make sure you have facilities that accommodate people. Don't get all caught up in blame or disrespectful language. I heard a story today about a person who was with her personal trainer at the gym, and the personal trainer was like, "You look great. You're succeeding. You're definitely slimming down. You're fitting into your clothes." But she's like, "No. I'm exercising because I want to be stronger and I want to feel better and I want to have more energy, not because I want to look different or I want to change the way I fit in my clothes. I just want you to know that those are my goals. She's like, yeah, but you just look so much better. What she doesn't know is this person who's her client, the personal trainer's client, has battled with emotional baggage, being told her entire life that she's not good enough, that she doesn't look good enough, that she's ugly because she's fat, because she hasn't been able to fit into those societal norms and stuff. So you're actually trying to compliment someone, but you're actually just, reopening that, sting, that cut that's been there. So anyways, just be aware in healthcare that you have some biases. A compliment is not always a helpful, constructive thing. You need to know that there are people who have baggage, they have an eating disorder history, they have, situations that make them respond differently than you would expect. So these are some of the dangers of telling people to diet and that they need to be different than what they are. Disordered eating. Have you heard the term orthorexia? That's an unhealthy attempt to focus on healthy eating. So you think you're eating healthy by eliminating all sugar and all fats, and next thing you know, you're malnourished and you're focusing on this so much you have horrible energy level and disordered eating. Weight cycling, the yo-yo dieting, that's a problem. Stigma, obviously, poor mental health, clearly. So evidence against dieting, this has been more and more throughout the decades, but I think a lot of people don't realize how harmful attempting to lose weight is through dieting. It's not only not effective most of the time, but it's actually harmful a lot of the time. And I think a lot of people don't realize that. Yes, I have actually lost weight dieting. I think it's been successful. I think it's been long-term. I think it's contributed to my overall health. Many people have. But the question is, what do the majority of people experience when they try to do this as an intervention? Is it something you can just assume that the benefits outweigh the risks of telling someone to go on a diet? They don't. So if you believe the data, they don't. So dieting typically leads to regaining lost weight. Short-term weight loss, yes, but it's often not sustained long-term. So the Biggest Loser show, those people just had a huge amount of rapid weight loss, and then afterwards, their health was destroyed. So if you follow some of those and find out afterwards how their metabolic health was destroyed, it is remarkable. How effective are diets in meta-analysis? 95 to 98% of the dieters in this 2015 study on a meta-analysis regained all the weight lost. If you just go out long enough, they all gain it back, essentially, except 2%. That is not a great intervention. 1/3 to 2/3 are worse off. They gain more weight than they started out with as you follow them out long term. So why in the world would we be recommending an intervention to someone that leaves them less healthy and worse off? This is summarizing the argument from the anti-diet book. I think she's cherry-picked her data a little bit. I don't think it's quite this dire, and I think diet probably does help more people than this would indicate. But it's something to chew on, it's something to be aware of, and it's something to know that patients come armed with. And when you tell them to stand on that scale and that they need to lose weight, they lose respect for you and they're going to look for a different doctor. So you just need to know this is the dialogue. This is what's happening in our community. Intuitive eating, I'm running out of time, so I'm going to go fast. Intuitive eating is kind of an alternative to dieting. It's eat what you want when your body tells you that you need it, and then stop eating when you're not hungry. Listen to those signals. Some version of that is in the McFarland. Every year they send me an email that says you can download this app, Wonder, and it's got videos, and it's a version of intuitive eating. Some people in the anti-diet movement criticize Wonder, and they say it's not real intuitive eating. I don't have time to go into that, but you can look up Wonder, WONDR. It's missing the E. That's an app that's free to McFarland employees if you sign up in January. I think it's a good program. I've enjoyed it, even though it's probably not the most successful thing for me personally. Health at Every Size is a movement that attempts to allow people to be healthy, do the things that keep them healthy without a focus on their size. And I think that's a worthwhile thing to do. I think that there may be a danger in not ever talking about size because I think size has some relevance, but I still think that it is a step in the right direction to make sure you focus on behaviors and not so much just what their body looks like or what their body fat is. So what does work? We're going to talk about GLP-1 medications here in just a minute. Rachelle's going to take it over, and so I'm not going to cover that much, but I will say that over decades, we've had no great interventions for helping people to lose weight. And that's especially why diet culture is like, then why are you telling us to lose weight when you've got nothing that actually works? Well, now we do have something that works. But some of them are like, I still don't want it because I don't need it, because I'm happy with my body the way it is, and I don't need anybody telling me that I need to be different than I am. So there's some resistance there because everyone has their own biases when they come into a situation. But at least for the purpose of what's useful, these medications are very successful and they have a lot of promise. I'm going to skip this. And then we've got another couple cases here. A coworker is using GLP-1 medication despite not being overweight. I just wanted to point out that you don't know sort of how someone got to the body size that they're at. Maybe the coworker was actually 50 pounds overweight, got started on that GLP medication, and now needs it to maintain. And so even though they're not overweight anymore, they need that. And it's actually a decision that's made between them and their healthcare provider. And so you got to be really careful about assuming that people shouldn't be on a medication. It's really controversial in our society right now, how these medications are used and that sort of thing. And then the final case is the patient has acute, insert whatever you like here, fasciitis, plantar fasciitis, sciatica, sleep apnea, whatever it is. And their doctor says, oh, I know what that is, and I know just what you need. You got to lose weight. So we're not going to do any kind of audience polling on this, but I hope you gathered from this talk that they're not pat answers. And telling patients to lose weight is not productive. You have to get into the why, the what for, what have they tried, how are we going to do this, what's the most effective. Exercise has benefits, even though it's not great for losing weight. Quite honestly, you only lose 1 or 2 pounds if you believe the data after staying on a dedicated program. But diets are particularly not great for losing weight because you lose it temporarily with a crash diet, damage your metabolism, and then gain it all back. So some people it works for. Some people it's a perfectly acceptable approach. You need to customize that. You need to be sensitive as a healthcare professional. So take-home points are the same ones I had at the beginning. Hopefully, if you have any questions on how everything I've said connects to that, jot them down, and I'll take some questions at the end, but I've already taken some of Rachelle's time, so I'm just going to go ahead and end here. You can take a picture or snapshot of this if you want some recommended reading, educational resources from the Health at Every Size movement, and then that Wonder app. Take a picture with your phone or come back to it on YouTube, and I'll turn that over to Rachelle.
All right. Thank you, Dr. Hopkins. That was fantastic. A lot of important points there. I am going to mostly focus on the GLP-1 medications and some of the issues with those, which I don't really know that there are a lot, really, but no, there are. So, disclosures, I am a DNP with Iowa Weight Loss. We have a space here in the hospital where I see patients, and I am the founder-owner of the Iowa Obesity Society to advocate for patients with metabolic diseases. So learning objectives, understanding the efficacy and indications of use for GLP-1s and why they're in such high demand. And we're going to identify some barriers and potential solutions in providing quality care for patients with diabetes and obesity. Overview. So the development of GLP-1 medications for the treatment of diabetes and obesity and numerous exploratory indications have been revolutionary, and they offer hope for the future. Studies in the 1960s found that oral intake of glucose had more of an effect on sustained insulin release than IV administered glucose. Initially, GIP was discovered, and that phenomenon was termed incretin effect, which is impaired in patients with type 2 diabetes. So in the late 80s, they discovered GLP-1, or GLP in general, and they noted it had a more significant incretin effect than GIP, so it was a great drug target. Not only did GLP-1 affect insulin release, but over the years, many other effects have been noted throughout the body as well. The GLP-1 receptor agonist was FDA approved for the treatment of type 2 diabetes in 2005, so relatively new. Currently, there are about 85 new medications in phase 2 through 3 trials targeting diabetes, obesity, and associated conditions such as cardiovascular risk and liver disease. While this is fantastic, there are a few less than minor issues with them. Recent medication shortages, particularly with the GLP-1 drug class, have resulted in unprecedented concerns, questions, and controversy surrounding current policies and procedures in place to regulate manufacturing, marketing, prescribing, procurement, dispensing, and reimbursement practices within the healthcare system, and access to the general public. These meds are expensive. Insurance coverage is often not great. The prior auth process is very difficult. They can be very confusing and time-consuming to dose and manage if you're not super familiar with them. The side effects are not fun either. There's shortages. The prices are just ramping up every single day. It's ridiculous, very much in demand. Social media exploitation has really contributed to increased stigma and bias. And so these patients are really feeling alienated that way. Diabetes and obesity stats. So about 10% of the US population has diabetes. 90 to 95% of those are type 2. About 20% don't know they even have it. And I see that all the time. I'll have a patient come in, they'll have an A1C of like 7%. And they're like, no one's ever told me that. They just told me, watch my carbs and exercise. So we really need to focus on that for sure. 90% of adults with type 2 diabetes are also overweight and obese. Losing as little as 5 to 10% of your overall body weight can greatly improve type 2 diabetes. A 15% weight reduction can be enough to cause remission of diabetes. Having both obesity and diabetes certainly increases the chance for heart disease, which is the leading cause of death in the country, and it's preventable. So we really need to do better with prevention, beginning preconception, but here we are. So a quick detour. Our bodies really are amazing. So there are many different processes in place to maintain homeostasis. However, external forces that have thrown off our body's ability to maintain homeostasis as it's designed do result in disease processes. So it really should be calories in, energy out, a perfect equilibrium, but it's not. There are a multitude of factors contributing to metabolic disease processes, and it's become very complicated. So don't just assume a patient's nutrition and physical activity are currently inadequate without doing a thorough assessment. Telling a patient to eat less, exercise more, without providing detailed advice is not beneficial. So for metabolism, I do metabolism testing in our office. It is kind of a thing that people think if your metabolism is fast, you have a lower BMI. Not true. Slow does not mean you have a higher BMI. So when a patient comes back and we test it and they're fast, usually it's because they're either significantly exceeding their caloric needs or they're super active or it takes a lot of energy to move their body, so they come back fast. Slow often is due to patients overly restricting their caloric intake for a long time or someone who's just super sedentary. So the metabolism is normal if it's plus or minus 10% from the baseline. Up to like -30 I have seen is super, super slow. So I had one patient, she was eating like 1 egg, 1 granola bar a day. She was wheelchair bound. She could walk a little bit. Her BMI was over 50. She had multiple comorbid conditions. Her body fat percentage was 54%. Her doctor just told her, you need to eat less and just move. She couldn't. So we did the metabolism test. Our dietitian worked with her, got her eating and making her, getting her basic protein needs met, getting her fruits and veggies in and such. And we referred her to Mary Greeley's aquatic therapy, and she loved it. And she finally got her joint, and she's doing much better. Another patient that was -30, they were eating nothing all day, going home, having a big dinner. She's a secretary, no physical activity really. BMI is only 24, no comorbids. Her body fat was 41%. Her doctor told her, you're healthy, you're doing fine. I don't know what your concern is. So she came to us and I did tell her, you don't qualify for like a weight loss medication, but by all means, you could establish an exercise routine, including strength training, and eat your protein, get your meals in throughout the day, because if you're not getting that energy coming in when you need it, your body's gonna slow down your metabolism to make up for it. So she did that and her muscle mass improved, body fat percent went down. She had a lot more energy as well. So, and then for fast people, plus 30%, these are a couple. I had a guy come in his 40s. He was eating about 5,000 calories per day. He worked construction. He was maintaining an acreage. He had a BMI over 50. He did have hypertension and high cholesterol. His A1C was 6.7%. he did not know he had high blood sugars. Body fat percent was 51. So he was told by his physician to eat more exercise more, eat less. So certainly he is probably overeating, but he was eating mostly protein or carbs, high sugar foods, processed foods, because he was in a hurry and he was busy. So we helped him kind of look at his nutrition, get better nutrition in. And once he was meeting his nutrition needs, he didn't feel like he needed that many calories anymore, and he had a lot more energy. So that did help him out quite a bit. And his comorbids all did improve, and we did do a GLP-1 with him. And then another fast one was eating 1,600 calories per day, lots of protein and produce. She was working out hard 5 times a week. She was a young gal in her 20s, working as a nurse's aide. Her BMI was 31, body fat 24%, no comorbids. Her doctor referred her to us for weight loss. I told her she was very, very healthy, yes, and she did not need to lose weight, and her body fat percentage is fine. So that goes on to hyperpalatable food-like substances. This is a big issue for these patients. So a lot of the foods that are highly processed, they have high fat, sugar, salt, chemicals, very little nutritional value. Sometimes you got to feed your soul. So yes, I'll have something like that here and there. But big picture, they artificially stimulate the reward center in your brain. So when you intake these things in nature, if something tastes good, it's probably nutritious. Your body encourages you to eat more of it for survival because you found a good food source. With these meds or these foods, marketing really will target like visual stimulants so people will see it. They make them look attractive and great and trigger cravings as well. Consuming large amounts of them don't nourish your body, so you'll eat more and more. Your brain's getting stimulated to make you eat more. It overstimulates your pancreas, it confuses hormone signaling, messes with your metabolism. It actually increases hunger as the body needs nutrients and wants more nutrients. It increases inflammation. I see a lot of patients who are consuming high amounts of those with protein malnourishment. Plus, they are targeting our highest risk populations, the people who are super busy, working hard, they've got little kids, 2 jobs. They're available, they're convenient, they're cheap, they're shelf stable. The stigma and bias further alienates them. Sometimes they don't know that these aren't super healthy foods. A lot of the marketing scams also will say they're nutritious, or high protein is really common lately. So not always true. And they may not have access to good storage and prep throughout the day, so they're easy, shelf-stable, grab and go. This is just an example of kind of what 14 calories-ish looks like. So on the left, those are very high calorie, not very nutrient dense foods. And then on the right side, that's also 1,400 calories, but we're getting good quality proteins in, fruits and vegetables, some whole grains, lots of fiber, good water content in the whole produce items. So that's a big difference. So common things I see are that patients like to avoid protein because they're worried about the calorie and fat content in them. So that's not getting met. A lot of them don't know how to prepare veggies or cook them. And also an important thing to understand too is when a patient does lose weight and they do great, they never arrive at that perfect weight and then just live their fantastic life. It takes ongoing sustained changes with their behavior and lifestyle in general. And I usually focus more so on how they're feeling, not like weight loss as the goal. So pathophys, this is super simple. So I simplified it completely. There's like in your resources, if you want to take a deep dive, feel free, but it's a lot. And interestingly, we don't really know a lot. With all we know, it's not a lot. We have developed drugs to hit a certain target. They don't work. We don't know why. So obesity is a mild state of chronic inflammation of adipose tissue. The chronic inflammation results in hormonal and immune dysfunction. Excess adipose tissue, primarily visceral fat, creates resistance and secretes inflammatory markers that directly influence tissues and systems that regulate homeostasis throughout the body, maintaining your blood pressure and your energy balance. Obesity is the primary disease causing diabetes and other comorbid conditions, thus it should be treated aggressively and prevented. The pancreas and liver primarily manage the level of glucose in the bloodstream. Several genetic and lifestyle factors can contribute to insulin resistance as well. Excess adipose tissue may lead to fatty liver. So there isn't enough room for glucose to be stored adequately within the liver, so it stays in the bloodstream. In response, the pancreas produces more insulin. Without intervention, the issue kind of snowballs and escalates to the point then the patient has diabetes eventually. Even modest reductions in fat mass can reduce resistance enough to prevent or reverse diabetes. And yeah, some people have a higher BMI and their liver and their pancreas are perfectly healthy, and that's fantastic. So I also will look at labs, other factors and such as well. There are a lot of medications that can induce insulin resistance, hyperglycemia, and increased tendency to want to store excess fat. Hormonal disorders can be present, certainly genetics. Talked about the food quality, that is huge. Inactivity, that is a big one. So muscles obviously run off of glucose, and not activating them does not burn up that energy. So very important. I didn't put microbiome on there either, but that one is a good one as well. So due to the various factors contributing to escalating incidence of diabetes and obesity and our lack of preventative measures, we go to medications. So this kind of displays all of the effects of the GLP-1 meds. There are a lot of them. I do have a lot of patients ask about the long-term effects of these drugs, and I feel perfectly fine telling them they're relatively new. We don't know everything about them. Give them the facts and let them decide. I do encourage them to have a plan to continue on them long-term. They're not meds meant for a short, quick fix. The effects most noted by patients are improvements, of course, in blood sugars, blood pressure, cholesterol, activity tolerance, obviously decreased appetite. Many note reduced food noise or thoughts about food in the absence of true hunger. Considering the inflammatory properties of obesity that directly lead to diabetes, I've also witnessed significant improvements in chronic pain and exercise endurance. Common side effects are certainly nausea and vomiting, especially if a patient eats too much or eats too fast. Constipation, especially if not getting adequate fluids, and fiber is common. I also see increased acid reflux with that. Usually from the slow digestion, the constipation just kind of backs up. I have had complaints of like sulfur burps. That's kind of thought possibly due to a decreased ability for the pancreas to produce the digestive enzymes. That does get better over time. Otherwise, I'll reduce the dose for like a few weeks and they do better. Increased urination has been reported, and certainly dehydration is a huge concern with these drugs. I've only seen diarrhea really a few times, and that couldn't really be contributed to poor food choices or anything like that. Fatigue, increased heart rate, sometimes noticed, but that makes sense because of the improved cardiovascular effects. So diet and exercise often are not enough on their own. Muscles, as I said, get their energy from glucose. So as patients try to increase exercise, the glucose cannot move into the muscles like it's supposed to due to insulin resistance, and they can't tolerate their exercise. So overall, GLP-1 slows digestion and glucose spikes, increases insulin sensitivity and glucose uptake while decreasing glucagon secretion. It's also vasodilating, so the muscle perfusion improves, and I often will see patients primarily lose more so fat mass and maintain muscle pretty well on these meds. GLP-1 is a smart drug. It is naturally released from cells in the gut when you're eating, of course. So you probably know the functions of the pancreas and such. So since time's kind of getting low, I will let you read that yourselves. But one thing that's really important to note is these drugs are smart drugs. They don't in themselves prevent or cause hypoglycemia. They are not contraindicated even in patients with type 1 diabetes. So that's important to know. So certainly we want to treat diabetes. I kind of went over all of that before. I'm sure you're familiar with the AACE algorithm. Biggest focuses now are cardiovascular events and kidney failure, trying to avoid low value use of these meds. Usually we want, the lowest effective dose for meds. With the GLP-1s, you really should ramp them up when you're treating diabetes in conjunction with somebody who does have overweight or obesity and really target that. Also, referring them to a diabetes educator can be really helpful. So in light of that, if you have a patient who does have diabetes and obesity, you really want to target the obesity. The medications are dosed higher for that. So diabetes or GLP-1 is first line for patients with diabetes and obesity. Obesity is the underlying factor in most chronic disease processes. So you want to treat those conditions until they resolve. And certainly putting in referrals can be really helpful. You don't have time to do all of this in primary care. This is kind of about the other weight loss meds. I just put kind of what I usually use them for and what they target. It's good to just be aware of them. And then prescribing the GLP-1 meds. So some things with that. So both the name brand versions of semaglutide and liraglutide, they are the exact same drug. They're just branded under different names. Dosing recommendations vary based on whether you're targeting A1C or weight loss. So providers know this. We want to get our patients the medication that they need. So recently, some providers who've written a lot of off-labels have been getting letters from insurance companies and PBMs saying that they're investigating them for fraud. Off-label prescribing is not illegal. It's perfectly fine, so long as you're not fraudulently diagnosing a patient with diabetes to get them Ozempic or something like that. Otherwise, insurance companies have really caught on to the off-label stuff lately, though. So there are a lot of really rigorous PAs in place. They are really promoting on-label use for these meds. And that does also help highlight, these patients here are using them to treat their obesity so we can get better data on that, whereas these people are targeting their A1C so we can get better data on the effects of those meds for those patients and outcomes. The Pearls best practices. You can read through those yourself as well. We've only got a few minutes. But really importantly, these meds should be prescribed with education and monitoring. They should not just be willy-nilly ordered off the internet and taken without any direction. The side effects can be really serious, and ER doctors are not happy about some of that. So. Barriers, there are significant barriers. There is no generic available for the GLP-1s, and there are a few options available with acceptable weight loss profiles, so they are really limited in supply. Medicare and Iowa Medicaid actually prohibit coverage of weight loss meds, and it will take a policy change to change that. Talked about the prior auth issue. Pharmaceutical reps cannot talk about off-label or experimental uses of drugs, so it is up to the provider and the medical community to stay up to date on new research developments. About 20% of the meds in the U.S. are used for off-label purposes, and that is based on post-FDA approval studies and new data that emerges, and they usually don't update the label. So you can expect that, and you just kind of have to go with your own judgment, and when you want to prescribe something that makes sense, you should be able to back it up and do so. Social media is a big issue. I'm sure you're aware. And then compounding, big picture compounding. These drugs are not generic. They are not manufactured by the manufacturer who makes these drugs. The manufacturers have found a way to isolate the pure molecule. And that is when what you're injecting, it binds to albumin in the system, and it is a very stable, reliable way to administer these. The ones that are compounded did not pass FDA approval because they are bound with either acetate sodium. It's a very unstable carrier. I have patients that come in that are getting them from spas, and they are either not having any effect or they are so sick because who knows what they're really getting and how much drug is getting actually in their system, and it's not going to be steady, and the efficacy is just not there. So in your handout, there are statements by the OMA, FDA, and Novo put a statement out as well. And moving forward, the scientific goal is to elucidate obesity pathogenesis so as to better inform treatment, public policy advocacy, and awareness of obesity in ways that ultimately diminish its public health and economic consequences. And I already told you there are a bunch of new meds in studies, so that's exciting. So going ahead, competition will improve supply issues, drive down costs, so I'm looking forward to that. New advancements are definitely improving also the efficacy and options even for the current meds. They're changing the way they're delivered and such like that. News releases, I put links for those in your handouts. And then main takeaway is really that medical professionals, we need to really understand the efficacy and indications of use for these meds, educate patients on what's fact, and question current practices so we can lead to positive change, because there's a lot of stuff going on that's not great. And then these are some helpful resources, things that the organizations I'll go to for advice and to make sure I'm on top of my game. So that is it. Yeah, we can take questions for sure.
We got a couple minutes. Mike?
Dr. Hopkins, at the AMA meeting this summer, was there a push to try to get the insurance companies to cover this?
To be honest, I don't remember. So I think that there always is. I think that the AMA's position is that the decision about whether these things are going to be valuable to patients should be done by a physician and someone who's caring for the individual, not an insurance company with a policy that's across, how to save money for the shareholders and, limit accessibility because of saying it's experimental or that it's not data supported.
Yeah, the McFarland Clinic Benefits Committee has actually looked at this, and we've made no decision about whether to pay for the GLP-1 drugs, but it may be happening sometime in the future.
Yeah, I have seen for certain insurance companies, they do rely on the employer to add them to the benefit package, so they're kind of putting it on them. It's scary that there's not a lot of data out there yet. I would love for all of my patients who need one to get one, but the prices have really gone up. The supply issue is horrible. There's a lot of unknowns. There have been some studies showing how if they do add these widespread to everyone who could possibly get them, it's going to crash our health system. So hold tight. I really, really think that when there are a bunch of new meds out on the market available, costs will go down. They will be more plentiful. We'll be able to cover them. We'll have more data.
There's also a huge pipeline for new medications. And so that, it's just like the infrastructure we were talking about, supporting electrical vehicles. Well, we don't have the infrastructure now, but it's going to work in conjunction. It's kind of a similar type of a deal. I think that as their demand goes up, the price will come down. There will be more options. And I do just want to say, in terms of whether it pays for itself, this was kind of like a book report, grand rounds for me. I read this book and based my whole talk. Another book I read recently was Peter Attia, and he's talking about longevity and health span, how to live a healthy life, not just a long life. And the 4 horsemen of the apocalypse, basically he's talking about is neurodegenerative, cardiovascular, cancer, and metabolic disorders. Well, if you can just bring down the size of the population in terms of obesity, you're going to have way fewer problems with all of those. And you look at the drugs that we use to treat them and how expensive those drugs are. And you say, well, maybe it's not that expensive to use GLP-1s if it replaces a whole host of other medications that are all extraordinarily expensive as well. So it's complicated. We don't have the data, but in my view, we know it works. We have it available. And let's let the market sort of make those decisions rather than us withhold those from patients who can benefit from them. That's kind of where I am.
Mm-hmm. Yep.
Any other questions? Thanks.
Okay.